Sir.
Sir, good morning, sir.
Good morning. Okay, good.
వచ్చినాయి కదా సార్?
వచ్చే సార్. స్లైడ్ షోకి వెళ్ళండి సార్. డీటెయిల్ గా రాలేదు. స్లైడ్ షోకి వెళ్ళండి సార్.
స్లైడ్ షో అయితే సార్ చూస్తున్నాను.
పైన ఎక్కడ ఉంటుంది?
కింద ఉంటుంది మోహన్ రావు.
అదే పైన కింద రెండు దగ్గర ఉంటుంది సార్.
ఉంటుంది సార్, మీకు ఎక్కడైనా కనిపిస్తుంది. అలా వస్తున్నాయి ఏంటి అసలు స్లైడ్స్?
అదే
సార్ అది పీపీటీయా పీడిఎఫ్ ఫార్మెటా?
పీపీటీ సార్.
మంజులో ఉంటుంది. మంజులకు ఫోన్ చేసి అక్కడ ఓపెన్ చేయమని.
Sir, tell me, sir.
మంజులా ఓపెన్ ద పీపీటీ.
He is in our room, no? Department room, no?
No, sir.
సార్ ఎక్కడున్నారు?
ఇది మెయిల్ నుంచి డౌన్లోడ్ చేయండి సార్.
No, first download, Suresh.
సురేష్ గారు
డౌన్లోడ్ చేస్తున్నాను సార్. డౌన్లోడ్ ఆప్షన్ అవ్వట్లేదు అది.
మీకు
సార్ చూసారు ఇప్పుడు సురేష్ గారు?
సార్
ఇప్పుడు
ఇది నేను చేశాను. నేను స్క్రోల్ చేస్తానండి.
సరే
సార్
సార్,
అయితే నేను వచ్చినా సార్
మీరు అవుట్ అయిపోయారు. నేను షేర్ స్క్రీన్ చేశాను.
ఎస్ సార్, థ్యాంక్ యూ సార్.
మోహన్ రావు ఫుల్ స్క్రీన్ లేదు.
ఫుల్ స్క్రీన్ ఉంది సార్, చూడండి.
లేదు
డేవిడ్ గారు?
లేదు సార్, ఫుల్ స్క్రీన్ లేదు. మీరు స్లైడ్ షోలో పెట్టారా?
నేను పెట్టాను, చూడండి. ఇప్పుడు వచ్చింది ఫుల్ స్క్రీన్, చూడండి.
రాలేదు.
నాకైతే ఫుల్ స్క్రీన్ కనిపిస్తుంది.
అందుకోసం మళ్ళీ వెనక్కి
బషీర్
చెప్పండి సార్.
ఫుల్ స్క్రీన్ రావట్లేదు అంట, ఒకసారి చూడు
సార్. ఎందుకంటే అక్కడ పైన ఎనేబుల్ ఎడిటింగ్ అని ఉంటది చూడండి, అది క్లిక్ చేయండి పైన.
ఓకే ఫైన్. ఓకే
ఎనీబడీ ఎడిటింగ్.
ఓకే నౌ
లేదు.
నౌ
నో. ఉంది సార్.
ఓకే గుడ్. సురేష్ గారు
థ్యాంక్ యూ సార్.
సార్ షల్ వి స్టార్ట్?
ఎస్ సార్.
అవును సార్.
Shall we start?
సార్
ఎస్ సార్.
డేవిడ్ ఇంట్రొడ్యూస్ చేయమంటారా సార్?
నేను స్టార్ట్ చేస్తాను, మీరు ఇంట్రొడ్యూస్ చేయండి సార్.
అలాగే సార్.
Good morning, all of you. I must be thankful to Dr. Suresh Kumar, MD, DM, Consultant Neurologist in Medicover Hospital. Thank you, sir, for accepting to talk on this very important topic in a very early time. And we hope we are all the intensivists and the PGs will get benefit out of this talk. Thank you very much, sir. And now I request Dr. Mohan Maharaj to introduce the today's speaker, sir.
Good morning, all. I'm really thankful to Dr. Suresh Kumar, who is very young, dynamic, always smiling neurologist, who is actually very young and knowledgeable, and he has done his MBBS from KGH Visakhapatnam, and he has done MD from Guntur Medical College, and he has done his DM from NIMHANS, Bangalore, and he has done his 1-year SRship from KGH, and he has a lot of connections with the international authority of people of epilepsy, and who's advanced, even now he connects with his own institute, and he always have the differential diagnosis. He really enjoys the clinical side and bedside discussion and diagnosing the new things if it is required, and not sticking to only the micro things he analyzes. So I'm very thankful for him, and with his knowledge sharing, I'm sure that we all will get benefit by serving the more and more neurology patients. Thank you, sir. Please request to start.
Thank you very much, sir. So thank you very much for your kind words. Not that much things, sir. I learned most of the patient care from you only, and the way you process the patient and the way you are corresponding with other people and your juniors. That should be, it's like vital, sir. Today's topic is interpreting the neurophysiology. Interpreting the neurophysiology mainly on the nerve conduction and the EMG, also called ENMG, means electroneuromyography. This mainly consists of nerve conduction studies, needle electromyography, and special studies like late responses, blink reflex, RNS, and single fiber EMG. Today we mainly concentrate on the nerve conduction studies, both sensory and motor, and some words about the electromyography. These special studies like late response mainly assess the proximal part of the neuroaxis. So that is late response is mainly F wave and X reflex. This assess the root pathology. Blink reflexes mainly assess the cranial nerves, mainly 5th and 7th cranial nerve, that monocranial neuropathy, we can assess the blink reflex. This RNS is repetitive nerve stimulation. This is mainly to assess the neuromuscular junction pathology. And RNS, there are so many types, it's like 3H and 50H. 3H is for the mainly neuromuscular junction pathology, mainly the myasthenia gravis. And Lambert-Eaton is in the higher side of the The single fiber EMG also assess the pathology, mainly in the neuromuscular junction and the nerve. Today, we mainly concentrate on the nerve conduction studies and basics about the nerve conduction studies and the needle electromyography. Next slide, please. The goal of the electrodiagnostic study is to assess the severity, and everything is like we must know that this whatever electrophysiology or whatever nerve conduction studies we are doing, this is an extension of the clinical examination. And the neurology is mainly of proper history, proper examination, and this extension of examination is called nerve conduction study. So we have to assimilate all the things, the history and the examination. From this history and examination, we should come to the conclusion and one differential diagnosis. And with the nerve conduction studies, we have to formalize our hypothesis, like whatever we are, whether it is root pathology or heart pathology or whether it is a mononeuropathy or multineuropathy, like that. So it's an extension of the examination only. Sole EMG or nerve conduction doesn't give you any clue. It should be combined with your clinical examination and history. So mainly goals of this electrodiagnostic study is to assess the severity and to localize whether it is pertaining to one muscle or nerve or neuromuscular junction. If it is muscle, is myopathy, is acute myopathy or chronic myopathy. If it is nerve also, whether it is axonal or demyelinating. If it is axonal or demyelinating, and the temporal evolution also, whether it is acute or chronic. By doing EMG and NCS, we have come to conclusion that whether the nerve is involved, a single nerve is involved, multiple nerves are involved, polynerves are involved. Single nerve is involved, mononeuropathy. Multiple nerves at different sites, mononeuropathy, multiplexer, and polyneuropathy. So, but mainly the neurology is more of localization and temporal evaluation. So, what are the consequences? Like, what is the history? How many days it has progressed, and all. With the help of EMG, we know whether only single muscle pathology is there, nerve pathology are combined, or neuromuscular junction, like that. Next slide, please. So coming to the anatomy of the PNS, sensory, first one is the sensory receptor. From the sensory receptor, it goes to the impulse goes to the sensory nerve, and then it goes to the dorsal root ganglion and sensory nerve. So any pathology beyond the dorsal root ganglion causes sensory nerve abnormalities. Later I discuss in detail. If the lesion is proximal to this dorsal root ganglion, if it is a lesion proximal to the dorsal root ganglion, snaps will be normal. I will show next slide. This is the second one. This is the motor nerve, pure motor nerve. Motor nerve, it comes from the anterior horn cell, and it forms the root, motor root, and it's covered by the myelin sheath, and it divides in the nerve terminals over the muscle. This is called neuromuscular junction. So these are two types of conduction. One is sensory nerve conduction, one is motor nerve conduction. In motor nerve conduction, we stimulate the nerve and we record the potential over the muscle. So we in the motor nerve conduction, we are assessing nerve, neuromuscular junction, muscle. In the sensory nerve conduction, we are stimulating the sensory nerve and we are recording the potentials on the sensory nerve. So in the sensory conduction, we are only assessing the sensory nerve only. But in the motor conductions, mainly we'll assess the motor nerves, but on top of that motor nerves, we'll also assess the muscle, neuromuscular junction also. Next slide, please. See, in this is a pure motor nerve conduction study. See here, these are the two records in the thumb. You see, two records, recording electrode R and stimulus point S1. This what you call S1 is called proximal stimulation. This is proximal stimulation. S2 is called distal stimulation. S2 is called distal stimulation. So here the negative means cathode. Cathode should be on the side of recording side. So cathode is in the black color. In the next, I will show the film also. The cathode is in the black color and anode is in the red color. So the stimulus, with the stimulus, you can record the stimulus. See here the first stimulus S1, that is proximal. You see the first proximal thing. See, amplitude is more. Why? Because is close to the recording side. S1 is very close to the recording side, and that impulses from the nerve is conducted to direct to the recording side. So this amplitude is more. So if you go to the S2 side means distal at the elbow. So we are recording at the elbow. So nerve impulses travel from the elbow to wrist and then to the thumb and then neuromuscular junction and then muscle. So it takes so much time. So it takes some latency and the amplitude also. So proximal stimulation has less distal latency because it is close to the recording site, and distal part latency will be the more and then the amplitude. Here we have to know that to differentiate between the demyelinating and axonal neuropathy. Demyelination is the covering layer, the nerve covering layer is lost. Means the fast conducting fibers are lost. So the impulses travel to this, the time to travel from the elbow to this joint, it takes more time. So distal latencies will be prolonged. So once the latencies is prolonged, you see here the motor velocity is distance by latency of 2 minus 1. So distance will be the same, but latencies will be prolonged. So conduction velocities will be reduced and the latencies will be prolonged. So in demyelination diseases, latency will be prolonged and velocities will be reduced. In the axonal neuropathy, mainly the nerve bulk is stimulated. So if the axons are lost, the amplitude is reduced. That is called CMAP amplitude is reduced. So for the axonal neuropathy, you must concentrate on the amplitude. Amplitude reduction is mnemonic for the axonal neuropathy. For the demyelination, motor velocities will be reduced and the latency is also prolonged. So this I will later discuss how to differentiate between the congenital demyelinating neuropathies from the acquired demyelinating neuropathies. Next slide, please.
Main A diseases lo ivi test chestar sir to differentiate sir.
To differentiate between the demyelination and axonal, sir, whether it is chronic.
Yes, sir. Thank you.
So amplitude is reduced, I think, axonal type, sir. The velocity is reduced, I think, demyelinating and distal latency prolonged. The congenital myopathies like Charcot-Marie tooth and all, there will be uniform slowing. Uniform slowing because the demyelination is acquired demyelination is patchy, even though it is inflammatory mediated systemic. The entire nerve anta involved, sir. So only some part of the nerve will be involved and some part of the nerve will be spared. So the distal latency will be prolonged, amplitude not that much change. Here in the congenital neuropathy, congenital demyelinating neuropathy, entire nerve covering is lost. So there will be uniform slowing. Later I will discuss. Next step, please. See. Here also, so supramaximal stimulation from the two different type, motor stimulation and sensory stimulation. So you have to stimulate from the low current to high current. If you got the good amplitude at 25 amperes and all, slowly increase that from the 25 to 30, and we can recruit other parts. See here, this red line, only first two motor fibers are involved. If you increase the current and then recruit the other neurons also, everything also involved. So if you keep on increasing the stimulator at one point, all nerves are involved. That if you increase the current beyond that level also, there will not be any extra nerve firing. So instead of that firing, sometimes amplitude may also reduce. So first we have to assess the amplitude, and then 5 to 10% extra of the amplitude we have to give, and then have to record the motor potentials. Next slide, please. So coming to the interpretation, motor nerve, mainly we are concentrating on motor and sensory nerve conductions. Motor nerve conductions mainly assess the peripheral nerves. On top of that, already we have shown that it also involves the anterior onset root neuromuscular junction muscle, because we are stimulating the nerve and we are recording the potentials on the muscle. So from the nerve, the main motor action comes from the anterior onset. So if there is any pathology in the anterior onset, also there will be reduced amplitude. In the roots, also prolonged distal latency. Sometimes with neuromuscular junction disorders and muscles, because the potential is generated from the muscle. If there is any neuromuscular junction problem or muscle problem, amplitude is reduced. So the pure motor studies, we mainly will assess the pure motor nerve, but on top of that, we'll also assess how the functioning of anterior onset, roots, neuromuscular junction and muscles. But sensory, the only disorder of the peripheral nerves only. We are stimulating on the sensory nerve and recording the sensory nerve. So sensory nerves only abnormalities will detect on the only peripheral nerves only. But motor with nerve, muscle, neuromuscular junction and anterior onset also we can assess. Next slide, please. Same thing only. Sensory nerve stimulation is over the nerve and recording is also over the nerve. In contrast to motor studies, only nerves are assessed in the sensory. But in the motor, neuromuscular junction muscles also will be involved. Sensory conduction velocity can be calculated in one stimulation only. Why? Because sensory nerves, if you stimulate the nerve and recording them from the other side, if you stimulate from the proximal side, the sensory nerve potentials are very low compared to motor potentials. So stimulus point and recording point must be in a low distance only. It's like near to the stimulation point, recording side will be the recording point. Recording will be easy. If you stimulate from the far distance, that impulses has to pass from the sensory nerve and to come to the recording site. So this will be like some phase cancellation and all. So if you go further, it means if you stimulate at the wrist joint, you will get the sensory stimulate median nerve nice potentials. If you stimulate at the elbow, the sensory, you may not get the sensory stimulus also, because the impulses has to carry from the elbow to the wrist to the big segment of the nerve, and phase cancellations also will be there. To simple sensory nerve conductions, we will see in the problem of the distal segments only. Proximal segments, it may not be possible. Next slide, please. See here also the localization of the impulses. See, it's very important. Sensory root ganglia, proximal to the sensory root ganglia. First diagram, proximal to the sensory root ganglia means spinal cord and the brain, other things. So if there is any lesion in the spinal cord or proximal to the dorsal root ganglia, snaps will be normal only, because snap is mainly mediated through the dorsal root ganglia and peripheral sensory nerve. So if there is any problem on the peripheral sensory nerve, then only you get the absence snaps. If the lesion is too proximal, means beyond the roots and spinal cord in the brain, snaps will be the normal. But in the motor level, the anterior onset is the main feeding for the motor nerve. So if there is any lesion in the anterior onset, her motor nerve reduces the CMAP amplitude. So for the SNAP, when dictum is proximal to the dorsal root ganglia, SNAP will be normal. So means in the spinal cord at proximal to if there is an alpha radiculopathy, the root is compressing at the alpha radical. The sensory nerve, the L5 conducting sensory nerve SNAP will be the normal because it is too proximal, it is too close to the spinal cord. So indirectly it assesses whether the lesion is intrinsic in the spinal canal or outside the spinal canal. We can assess by the snaps. If the snap is normal means it is too close or the nerve is not involved. Yes. Next slide, please. One more interesting thing is conduction block. This conduction block is mainly assess the motor function, motor nerve functioning, and mainly the fast conducting fibers. So any demyelinating lesions can cause conduction block. If you observe the first diagram, that nerve is insulated with myelin. All nerves are connected with myelin. The second one, down one. See, yes, sir. Up one is all have myelin sheath. In the downside, you see some first one and the last part of the first one is there is no myelin. Second part is also some part of the nerve is not having myelin, and the fourth nerve also some myelin loss is there. Fifth is also some myelin loss. Some myelin sheath is the axon is well preserved, but the covering layer of the axon, that is myelin, is lost. So if the first one is the normal. So if you conduct this one is the nerve conduction is distal. Upper diagram is distal. Second one is the proximal. So if you conduct distally, that amplitude will be the more and latencies will be less. And the second one you see here that the proximal stimulation, intact myelin causes axon propagation of the axon potential and produces the CMAP. The CMAP amplitude both are good. See that amplitude is both are good, but only latencies is prolonged. This is the normal thing. Second one you see that if you stimulate beyond the demyelination, proximal stimulation, so some more fibers are demyelinated, so it takes more time to conduct. So see the last one, that amplitude is not maintained, and then it is also very less, and the distal latency is also prolonged. Conduction block is you have to compare the proximal distal amplitude and proximal amplitude. Distal amplitude, so distal stimulation amplitude by proximal stimulation amplitude. If it is more than 60% loss, let us conduction block. So here the distal, see the amplitude is more and the proximal conduction amplitude is less. So here it is a conduction block. Conduction block indirectly tells about the myelin status. If the demyelination is there, it's a conduction block. It reduces the amplitude also. See, initially I told that axonal loss is mainly for the CMAP amplitude loss is mainly for the axonal loss. See, if there is any reduction in the CMAP amplitude, it indirectly tells about the axonal loss. Here we see conduction block name. The last this one, this amplitude is reduced, but this amplitude reduction is not because of axonal loss, because axons are intact here. Only because that this myelin sheath is lost, so the nerve impulse has to pass through the long time because the granular node and all are dysfunction. So it takes more time to travel to the distal side. So instead of this one, what you call temporal dispersion and phase cancellation. So because of the temporal, so much time it has to take. So that for that amplitude is reduced. So this conduction block is very vital. If its conduction block is there, it indirectly tells about the demyelination, that too acquired demyelination. In congenital demyelination, conduction block is there. Yes, sir. Next slide, please. Same thing only. Here we see. Here I am representing three diagrams. One is normal. First one, A is normal. B is proximal lesion. C is distal to the lesion, dorsal root ganglion. Same thing I told you. the normal things, first one is snap. Snap, you see, micro, it's like microvolt, 10 microvolt. And CMAP, you see, it's millivolt. So motor potentials are large potentials, sensory potentials are compared to motor potentials, very less potentials. So if there is any lesion proximal to the dorsal root ganglia, see in the diagram B, you see the lesion at the beyond the dorsal root ganglia. So the dorsal root ganglia lesion is there, but the snap is preserved because snap sensory action potential mainly maintained by dorsal root ganglia and the peripheral nerve. So peripheral nerve is intact and dorsal root nerve is also intact. So if the lesion is too close to the spinal cord, snaps will be normal. That is B. See, if the distal lesion, say, dorsal root ganglia is blocked, then you see the snap amplitude is also reduced. One more thing we see in the red mark, that is motor nerve. Even though it's proximal to the anterior horn cell, if the lesion is there, here compared to normal, that amplitude is reduced, the second one, that violet color. Amplitude is reduced compared to normal because even that the motor neurons come from the anterior horn cell. The motor neurons arises and it mingles with the motor nerve. So any lesion from the anterior horn cell to the neuromuscular junction can reduce the CMAP amplitude. Yes, sir. This one initially I told you. Hereditary demyelination, first you have to see the conduction velocities. Here you see median, ulnar, peroneal, tibial, all are 20, 19, 20, 21 like that. Because that myelin is entered from the starting to end point, there is no myelin. So there will not be any conduction block. So uniform reduction in the conduction velocities will be there. The next slide, please. These are acquired. Acquired, some nerves are involved and some segments only involved. Here you see conduction velocity is like from proximal to distal, radial, see above the cervical groove it is only 40 and the radial sensory is 50. So this depends on the site of this thing. So acquired demyelination, that velocity drop will be there, but into the some regions only. Yes, sir. Next. You see, we'll discuss one case now. 38-year-old teacher with a history of progressive paresthesias and numbness initially started in the upper limb, then in the lower limb over a gap of 2 weeks. So here the first symptom is heralding symptom is sensory symptom started progressively and first in the upper limb and the lower and then upper limb. What is the odd point in this? See, most of the sensory neuropathies are length dependent neuropathies, nutritional and other things. First starts in the lower limb, then it ascends to the upper limb. Here the sensory symptoms started in the upper limb and then lower limb. So first non-length dependent neuropathy, this first started in the upper limb and then lower limb over a gap of 2 weeks. And then patient developed a progressive imbalance in dorsal columns also involved. So large fiber neuropathy with sensory symptoms with position and vibration also lost. And later on, after 1 week, patient developed quadriplegia. So over a period of 2 to 3 weeks, some sensory symptoms initially started with small fiber and large fiber, later on with position sense, and later on also these motor fibers also involved. On examination, cranial nerves normal, hypotonia in all 4 limbs, proximal and distal weakness of the limbs, absent DTR, joint position sense absent in the fingers up to the ankles. Clinical diagnosis radiculoneuropathy. It's like you see this case, what is your diagnosis? Yes, sir. Hello, mom, sir.
చెప్పండి సార్, వింటున్నాను సార్.
Yes, sir. Yes, sir. What is your probable diagnosis for this patient, sir?
సార్ మీరు మమ్మల్ని క్వశ్చన్ అడుగుతున్నారు. No, sir, because
సరే ఇది సర్వైకల్ రాడిక్యులోపతి ఉండొచ్చు ఒకటి, అండ్ సెకండ్ థింగ్ ఈజ్ ఇంబ్యాలెన్స్ ఆఫ్ ద పేషెంట్ వైల్ డార్క్ వాకింగ్ అని అంటే ప్రాబ్లీ ఈయనకి మరి
బికాస్ ఆఫ్ ద సెన్సరీ ఉండొచ్చేమో అనుకుంటున్నాను.
Yes, sir. Yes, sir.
బట్
Yes, sir.
ఒక ట్రాన్స్వర్స్ మైలైటిస్ లాగానైతే మీరు పిక్చర్ అయితే ఇవ్వలేదు, అంటే
Yes, yes, sir.
ట్రాన్స్వర్స్ మైలైటిస్ లాగా ఇవ్వలేదు.
Sir.
బట్ ఈ క్యాన్ ఇట్ బి ఎనీ సర్వైకల్ కార్డ్ ట్యూమర్ ఏమన్నా ఉండొచ్చా? Having
No, sir.
compression.
It started with upper limb symptoms, predominantly large fiber, sensory neuropathy only. On
Yes.
top of the joint vibration position sense is also lost.
Yes.
So posterior column on top with motor weakness. So sensory nerves are involved, motor nerves are involved, and then so the examination wise, severe proximal muscle weakness is also there within 4 weeks. So proximal muscle weakness indirectly tells about either muscle or root. So clinical diagnosis is nerves and root. The polyradicular neuropathy, typical GB syndrome, this one. So first started in the upper limb and progressed over 2 weeks, and then some walking difficulty, mainly sensory ataxia predominant, ataxic variant of GB syndrome disease. So this is the clinical diagnosis. How to prove this one? Please.
So
next slide, please.
usually it starts with lower limbs, no sir? In this
that is length dependent, sir. Sometimes non-length dependent, which is that is the odd point. Length dependent is mostly nutritional type and other congenital and other things. Most of the nerve pathology starts in the distal, but some nerve neuropathies or radiculopathies starts with proximal. So this is a little bit odd. So this is not a typical routine diabetic neuropathy or some vitamin B12 deficiency neuropathy, because it has started in the upper limb. That is a little bit odd. And it also involves the motor nerves, that is the proximal roots also, over a period of 2 to 3 weeks. So it is rapidly progressing neuropathy. First involves the sensory nerve, and then dorsal columns, and then the roots also, motor roots also. So it's like AIDP. So diagnosis is polyradicular neuropathy. So how to prove? Next slide, please. See this one here, the conductions. First one is median, right median, proximal stimulation, and at the EC.
లెంగ్త్ తక్కువ ఉన్నప్పుడు డిఫరెంట్ గా చూపిస్తారు సార్. అయితే మీరు చెప్పినట్టుగా షార్ట్ లెంగ్త్ ఉన్నప్పుడు
సార్
మీరు అన్నట్టుగా లెంగ్త్ తక్కువ ఉన్నప్పుడు డిఫరెన్షియేషన్ చూపిస్తుందా సార్?
అంటే లెంగ్త్ తక్కువ ఉన్న అంటే రొటీన్ గా మనం చూసే న్యూరోపతీస్ లైక్ డయాబెటిక్ న్యూరోపతి ఇవన్నీ సిమ్టమ్స్ స్టార్ట్స్ ఇన్ ద లోవర్ లింబ్స్ సార్, బికాజ్ న్యూట్రిషన్ కావాలి కదా. అంటే ఇట్స్ లైక్ డైనమిక్ న్యూరోపతి అంటారు, బికాజ్ దట్ నర్వ్ న్యూట్రిషన్ కమ్స్ ఫ్రమ్ ద స్పైనల్ కార్డ్ ఆర్ డోర్సల్ రూట్, అక్కడ నుంచి రావాలి సార్ వాటికి.
బికాజ్ జెకినా క్వశ్చన్ కదా, అందుకోసం. The person who asked the question, who answered was is DM Critical Care, who's the first DM from AP and Telangana, who's presently working in Citizen Hyderabad, sir. Srinivas.
Yes, sir. So
Sir,
here that right median nerve stimulated the wrist and stimulated the elbow. If you see the amplitude of normal median nerve amplitude is up to 4 is normal. Here it is 2.36. But you see the latency up to 4.5 is normal. Here the latency is 10.4. It's rise more than 2 times. And right, so the latencies are prolonged, amplitude is also reduced, but the prolongation of the latencies is more compared to the amplitude reduction. And nerve conductions also, you see, it's like nerve conductions are 4.8, like that. It says normally nerve conduction upper limb should be 35. So there is a reduction in the amplitude and distal latency prolongation also. Same thing, see ulnar nerve also. Ulnar nerve normal amplitude is up to 6. Here the amplitude is 1.4 and latency is 3.3. Here the latency is prolonged up to 5.4. So latencies are prolonged and amplitude is also reduced, but the latency prolongation is more severe, more remarkable than the amplitude reduction. Here the demyelinating pattern is there. In ankle also motor, common peroneal nerve, amplitude up to 2 is normal, here up to 1.2 is there. So some reduction in the amplitude, but latencies are prolonged. Coming to the sensory conductions, you see here it is giving you sensory conductions, right median. First, this one is median, so there is no conductions only, there is no snap. Second one also, right ulnar snap is absent. And last one, some triphasic waveform is coming. That is sural nerve. So here the sural nerve is, you are getting a nice snap on the sural nerve and absent sensation, sensory impulses from the median and ulnar nerve. This is also one hallmark of GB syndrome. GB syndrome, sural sparing. Sural sparing is a hallmark for the GB syndrome because we are recording the motor nerves in the upper limb, mainly median and ulnar, and sensory nerves also. Those are the very distal nerves, are very tiny nerves. But myelin is very less in that. So demyelination, in GB syndrome mainly affects that myelin. Demyelinating variant of GB syndrome mainly affects the myelin containing nerves. So this compared to median and ulnar, sural nerve has thick myelin, long fibers, so they can withstand initially. So if the sural nerve conduction suggests of upper limb absent snap with preserved sural, it indirectly tells about the diagnosis. Most of the time, sural sparing is a pathognomonic for the tonus. See here, the amplitude in the sural is 14.5, so it is maintaining. So this is a classical case of GB syndrome with sural sparing, progress over 2 weeks. Yes, sir. That's about the motor conductions and the sensory conductions. We'll go to the EMG. Next slide, please. Next slide. This one, sural you see, this amplitude is 14.5 is there, sural. Median and ulnar completely absent. So it's a GB syndrome, sural sparing. Yes. Coming to the EMG, how to do EMG. As for that, we have to educate the patient that we poke with some needle, and we have to prepare the patient, and we have to select which muscle we have to assess and other things. First, you poke the needle and you see the movements of the needle and any spontaneous activity is there, and recording the initial insertional activity, spontaneous activity, and then during voluntary contraction. You have to record all these events and then to give the final report. Next slide, please. See, steps, mainly 3 steps EMG. One is insertional activity. Second one is spontaneous activity. Third one is activation. Activation means the patient has to do minimal activity. That is MUB. And then interference, complete or incomplete. So insertional activity, we just poke the muscle and we'll see whether there is any abnormal insertional activity. Sometimes if there is any myopathy, like inflammatory myopathy, we'll get the insertional activity, exaggerated insertional activity. This spontaneous activity, once you poke the muscle and then ask the patient to relax, after sometimes like after 2 or 3 minutes, patient is completely relaxed, then you have to see this end plate noise, fibrillation, positive shock waves, and fasciculations. And then ask the patient to move the limb slowly. Then with the voluntary contraction, what's going on, like whether it is normal MUPs or abnormal MUPs. We'll discuss later in detail. Next slide, please. So insertional activity, muscle and membrane instability. If there is any instability in the muscle and membrane, there will be an insertional activity. It doesn't give you any clue, but it tells about the membrane is unstable. Most of the inflammatory myopathies will get this picture. A decrease in insertional activity, maybe first possibility is technical. We are not looking at this thing. One more thing is McCarthy's disease. From myopathy, metabolic myopathy with McCarthy disease sometimes causes this decreased insertional activity. Next slide, please. These are the fibrillation potential. Fibrillations and fasciculations. See, it's not at all. Sometimes it's like if there is any fibrillation or fasciculation, is indirectly it's like ALS. Not like that. So there are so many causes for the fibrillation. There is neurogenic causes, myogenic causes, even the neuromuscular junction problems also causes fibrillation. Fibrillation is like spontaneous activity that is recorded in the muscle. So mainly anterior cell disorders, any radiculopathies, Even though mononeuropathies all them cause fibrillation potentials. Next slide, please. The fibrillation potentials is like raindrop like. I don't have any audio, no? So this fibrillation is like more of raindrop kind of thing. EMG is more of auditory this thing. You have to recognize the sound and then you have to come to the conclusion. EEG is more of visual. You have to see the wave morphology and the pattern of the morphology. Then the EEG is more of visual. EMG is more of auditory. So with the what impulses are coming, what sound is like, whether it is regular or irregular, any pauses are there. So like that, and that the quality of the sound finally to the waveform. So visual impression in the EMG is less compared to the auditory impression. So this fibrillation potential, there are so many causes for this fibrillation potentials, but important thing is anti-horn cell disorders and motor neuron disorders mainly, and neuromuscular junctions. Sometimes inflammatory myopathies also causes fibrillation. All fibrillations are not ALS. There are so many causes for the fibrillation. Yes, sir. Next slide, please. So one more thing that once the insertional activity is over, so whether we poke the muscle and then we have seen that whether there is any insertional activity. Once that spontaneous activity is over, then we need action potential. So this one is ask the patient to slowly flex the limb. Whatever the muscle we are assessing, that muscle has to be inflated. If it is the biceps muscle, the patient has to slowly flex the elbow. So in that, you have to see duration of the MUPs. Next important skills. So if it is short duration, no, first one, not at all. This is very important. Long duration potentials and short duration potentials. Long duration potentials are more of neuropathic origin. See, here are neurogenic disorder, motor neuron disease, axonal neuropathies, radiculopathies, mononeuropathies. So all long duration, big, this one amplitude is more of neuropathic. Short duration is more of myopathic. Very rarely neurogenic diseases can short one, that is early renervation. Later we'll discuss. Next slide, please. See, MUP and myopathies. See here, normally, see how many muscle fibers are connected to this needle. So there are so many muscle. They are giving the MUP. In the myopathy, the active muscles are dying. So that levels also reduce compared to one. See, MUP in normal muscle, that amplitude you see that is high, and short one is in the myopathy. So for the routine, this thing, myopathy are polyphasic, short duration, and neuropathic are large amplitude, long duration. Yes, sir. Next slide, please. This is due to the neurogenic process. This is over a temporal changes. See, initially first 1 minute, 2 months, 2 to 6 months, and more than 6 months. So initially, you see this red one and blue one are both are normal. But nerve is supplying, red nerve and blue nerve is supplying to the neuromuscular junctions. Second one, you see that one part of the nerve is gone, so the blue part is not there. So initially, that reduces the nerve impulses to the muscle. So that reduces the recruitment. So early sign of neuropathy is reduction in the recruitment. Recruitment will be reduced. Later on, the denervation and renervation is also started slowly. Some unstable maps you can observe. And later on, once this denervation and renervation process is going on, this polyphasic and long duration CMAP will be observed. Finally, after 6 months, only long duration CMAP, long duration MUPs will be observed. So initially, there is a early part of the nerve injury, there is a reduced recruitment. That is very important. So whenever we are seeing in critical illness neuropathy or critical illness myopathy, first this is more of axonal neuropathy. Even also GB syndrome also presents like equatorial. But how to differentiate GB syndrome from this one is axonal neuropathy predominantly, and then this reduced recruitment and all are more suggestive of critical illness neuropathy, acute neuropathy. Yes, next slide, please. So coming to the interpretation of EMG, is like you have to see the recruitment, miniature action potential, and variation, whether it is other. So simply, if the recruitment is reduction in the recruitment is more suggestive for early nerve injury. And if there is any short duration polyphasic waves are there, that is for the myopathy. Yes, sir. Next slide. Same thing only here. Depends on the duration and the MUP, you can categorize the disorders. If it is MUP is not. So this one, temporal profile in electrodiagnosis. This is very important. So each symptom, see, first day if you do the conductions or EMG in a patient, neuropathic patient of first day, you may not get the correct result because it takes some time to evaluate. So spontaneous activity appears on the paraspinal muscles after 10 to 14 days, and the proximal thigh muscles after 2 to 3 weeks, leg muscles after 3 to 4 weeks. So after the second or third week only, you will get this spontaneous activity and the denervated muscles. So, and if you do the CMAP also, you see CMAP begins to decrease by day 2 to 3 and reaches by day 7. So first to 2-3 early conductions in GB syndrome, it may come like normal one, because first 3 days conductions will be normal. Later on it slowly develops, and later on the 7th day to 14th day, it's like conductions will be abnormal. Snap amplitude also reduced by the 6th day, and it's coming to the nadir by 11th day. So initial conduction in the snap of, and in the sensory conductions also, first 6 days it will be normal only. Fibrillation potentials, that's a denervation, it occurs after 4 weeks. And axon is set. Yes, sir. Next slide, please. So from take-home message is that NCS, nerve conduction and EMG is a clinical extension of your history and examination. Nerve conduction and EMG is the only thing. And if there is any question, whether this is the electrodiagnostic, whatever information we got from the EDS, like nerve conductions, whether it is answering our clinical question or not. If it is not there, then we have to correlate everything once again. So there is no correlation between the nerve conduction studies and EMG with the clinical profile. We have to recheck once again, and then if it is not correlating once again examine the patient and give the report. Thank you.
Thank you, sir.
Yes.
Suresh sir, excellent presentation.
Yes.
And really, it is a very enlightening class. Till now, we don't interpret any of the NCS or EMG, and we don't know. Only neurologist will take care of that part. But as a clinician and intensivist, we should know all these things for exam purpose and in clinical purpose. Another thing, you selected a very good case, which is confused. Everybody after long experience also we confused to tell the diagnosis. A nice case you have selected and interpreted how to conclude Guillain-Barré syndrome. So it says importance of the nerve conduction study to come to a conclusion. I request the audience to respond. On, sir.
No, it's a nice class, and starting from the basics, I'm sure there are a lot of seniors are there in the group, Dr. Lakshmi Rani, Dr. Varalakshmi, Dr. M. Srinivas, and Srinivas, there. They can discuss some more. And I really thank you, sir, for your time and this one for me. I request others to communicate, and their students also, if they have any queries.
Suresh sir, nice presentation. Actually, last week also, Dr. Mani Prasad Reddy actually enlightened in detail about theory, and with your today's presentation, I think most of our intensivists actually happy, because how to interpret you have given in such a way that with a graphic presentation. And that is also, and one more thing, how frequently you will see, sir, this area in means our north coastal area, this neuromuscular problems?
It's like more of seasonal, sir. Is sometimes it is after the rainy season and after this viral infection, sometimes you get this TB symptoms, some pandemic kind of thing. It's like not like pandemic, some compared to incidents, it's usually like 1 to 6 per lakh. But that is some seasons it may be more like not rainy season and all, we used to see TB symptoms more. So it's like a paper from the NIMS also they published like seasonal myasthenia. The seasonal myasthenia is like they are presented like myasthenia because that is like tick-borne, more of a neuromuscular junction disorder. In some areas of the Karnataka also, they have published that they have observed after rainy season and some seasons, this TB syndrome suddenly spot in the TB syndrome. So we have seen also in the COVID era also, after COVID and in the second point, this thing, TB syndrome was more. We have observed more cases in that second wave.
So
for
apart
the
from that,
prognosis, sorry, something you were asking.
yeah, apart from this, we are regularly will get critical illness neuropathy, sir. So yeah, yeah. So best modality for monitoring is during the critical illness and during the recovery time, sir.
During the recovery time, see, this is the main. I forgot to cover that topic. Our mainly intensivist and neurologist interaction is more in that. So the patient has some respiratory tract infection, they let me in the respiratory department. And once the pneumonia, we give this thing, sedation, and after that, ventilation support and all. Once that pneumonia resolves, we expect the patient to come out from the ventilator. We reduce this thing, but patient is unable, like is not able to come out of the ventilator. Then you give a call to us. Routinely, these are the common interactions between you and us. So what will happen here? There are two possibilities. He might have some underlying neurological illness, but whatever aspiration, pneumonia, sepsis that brought him to the hospital, once that cleared, but this is unmasking this neurological status. Most of the time, either some CIDP, myasthenia gravis, or even though very rarely TB syndrome also present like that, acute respiratory failure and then so in the recovery phase, initial part of this thing, everything is improved and with vitals, everything, other things are improving and but he is not able to come out of the ventilator because of the neuromuscular weakness. It may be due to the critical illness neuropathy or critical illness myopathy. During the recovery phase, we observe that is more of axonal type. So we have to keep an eye on that. Most of the time, this main culprit for this critical illness neuropathy is evident use of steroids, steroids, and all that times causes this critical illness neuropathy.
Sir, Mohan sir and Mohan Maharaj and Jakina, do you have any postings in neurology department for the critical care students?
So
Sir,
we don't have any postings,
sir.
but we frequently do nerve conduction studies and we interpret with the help of we take the help of neurologists for interpretation. Sir, for the prognosis of, can I ask question? David?
Yes, please.
So for the prognosis of the patient, so we have started a treatment. Do we see a clinical recovery early or neurological this nerve conduction studies early?
Clinical recovery early, clinical recovery. So sometimes even though in the disease manifestation also, we do the nerve conduction initially in the first week of the GP syndrome. Positivity of the nerve conduction will be the 40%, only 40 to 50%. So clinical symptoms first appear and they disappear. Later on follows the nerve conduction studies.
So based on the nerve conduction study, we cannot prognosticate the patient.
And later on, I mean some chronic disease like myasthenia gravis and single fiber EMG depends on the single fiber EMG findings. You can adjust the immunomodulation. Depends on the etiology. If it is like acute, there is a one-time acute can go. So there is no need for the repeated conductions in that. But in CIDP and other some muscle diseases, you can repeat the EMG interval of 3 to 6 months and we can assess whether the immunomodulation is really working. This is one part of monitoring volume, but it is not by depending solely on the EMG finding, we can't come to a conclusion, because clinical improvement is more important. Yes, but there is some single fiber EMG studies are there in the myasthenia gravis to assess the aluminum modulation.
Okay, thank you. If you have a cranial nerve involvements and we feel that this is not means correlating with the stroke or bleeding, whichever is in the intracranial lesion. So how often you come across and do the nerve conduction studies for these patients?
Blink reflex, we can assess the facial nerve conduction, mainly 7th and 5th nerve. That is only that one part of the nerve conduction. It tells about the intraaxial, means like in the pons. It doesn't give you any clue, but it localizes the lesion outside the nerve or intrinsic. Like if you see the sometimes bilateral facial palsy is a presentation for the CV syndrome. So whether it is a nerve or intrinsic to the cord, that can be so. The ataxic variant also has this feature, bilateral facial nerve palsy with ataxia. We think that ataxia is there and facial palsy is there. We localize the lesion to the pons and we do MRI. MRI will be the normal. So then in the time, so we'll see. Recently we had a kid like that, some 8-year kid, pediatrician. She has presented with ataxia and bilateral facial nerve palsy. He has done MRI. MRI is completely normal. So element type of facial palsy. With the examination wise, he is having hypotonia and all. So we have done that blink reflex. It's corresponding to the nerve only. So in that aspect, blink reflex has a role. So
Suresh sir, good morning. Hello.
Hello.
Suresh sir. Sir, can we do EMG in a drowsy patient?
Yes, sir.
Can we interpret EMG in a drowsy patient?
Drowsy patient, spontaneous insertional activity and spontaneous activity we can assess, sir. But for the MUP, he has to move the limb, has to flex or extend the limb. It depends upon the muscle action. But he is not cooperating.
Sir, your voice is not audible, sir. Sir,
yes, sir. Yes, sir. MUP, sir, we can't assess MUP, sir, but this insertional activity and spontaneous activity we can assess. A drowsy patient, if he cooperates for the flexion and other things are okay. If he's not cooperating, complete interpretation will be difficult, sir. But some part of the EMG can be done. Mainly spontaneous activity and insertional activity we can assess.
But we can't make a diagnosis in a sedated or a drowsy patient, right, sir?
Yeah. If he cooperates sometimes and drowsy patients also, if you ask him to flex the active limb, we can do that. But EMG is difficult. At least NCS we can do with the help of other person.
Yes, sir.
EMG complete interpretation will be difficult in a drowsy patient.
Right, sir. Thank you, sir.
Yes, sir.
Good point.
Sir, as per your case scenario.
Yes, sir.
So most of the patients in ICU will be sedating kada.
Andukane sir question adigana. So andukane we can't do EMG and we can't make a diagnosis. NCS we can make this.
NCS yes, sir. EMG kuda spontaneous activity చూడొచ్చు. Spontaneous activity lo like whether there is any denervation potential, fibrillation, calcification అలాంటివి ఏమైనా అనుకోండి సార్. It indirectly tells about the nerve damage. But MEP yes, sir.
In that conditions, other option is muscle biopsy or nerve biopsy, sir?
Depends on etiology, sir. It's like if it is critical illness neuropathy or critical illness myopathy, nerve plus muscle you have to do, sir.
Okay.
First we'll do a narrow conduction study. With that narrow conduction study, we can come to a conclusion whether it is an axonal or neuropathy. Typical pure muscle disease in unconscious patient, that is difficult, sir. But with that insertional activity and spontaneous activity, at least we can rule out some neuropathic components. Pure muscle disease component difficult to assess.
Sir, if a typical case like what your case presentation, that case scenario,
Yes, sir.
if that case is purely neurological and patient is conscious, is it
Yes.
MRI is necessary?
Which one, sir? MRI. The patient.
MRI.
No need, sir.
For that. No need, no?
That kid, the
Routinely, some people will do MRI for any even neurological case.
Yes, sir. In this patient, no need, sir. MRI.
సార్ స్పైనల్ ఇష్యూస్ మరి రూల్ అవుట్ చేయగలమా ఎంఆర్ఐ లేకుండా? ఎంఆర్ఐ స్పైన్
అంటే ఎంఆర్ఐ స్పైన్ క్లినికల్
అంటే ఇప్పుడు అంటే మీరు చెప్పిన సినారియో ఇట్స్ జనరలైజ్డ్ సినారియో కదా సార్, అంటే మీన్ ఇన్వాల్వింగ్ బోత్ అప్పర్ లింబ్స్ అండ్ లోయర్ లింబ్స్ కదా. సో షుడ్ వి రూల్ అవుట్ ద సర్వైకల్ ఆర్ సమ్ pathology as Srinivas sir said?
But there is no bladder and rapid progression over 2 weeks. But there is no bladder issue, no sensitive level at trunk. There is
Okay, sir.
So clinical neurology is always clinical examination and district that gives you 70%. This investigation gives you narrows the differential diagnosis.
Okay, sir.
Yes, sir. Yes, sir.
David sir, Mohan sir, can we conclude, sir?
Yeah. Please. So much time he has been given, and so questions and even a good interaction. It was very nice. Thank you, David. Thank you, Suresh sir.
Thank you, sir. Thank you very much.
Thank you, Suresh sir, for a very good presentation and a very good explanations for all questions. And we need some more. Means still, I feel personally, still neurology some confusion will be there to understand. It's a very volatile subject. We need another talk from you for basics also, sir. Thank you, sir. Thank you all for your active participation. We'll close the session. Thank you, Suresh sir, once more for a good class. Thank you.
Thank you very much.
Thank you, sir.